So today's speaker is Charlie Henri-Bellemare. She's a master's student at McGill in the integrated program of neuroscience under the supervision of Martin Lepage and Millar Chakravarty. Today she'll be speaking about longitudinal white matter changes and verbal memory in the first episode, Psychosis. And she has welcomed questions throughout her talk, so you can either use the chat function or raise your hand.
Well, thank you, Katie, for the introduction, and thank you everyone for being here today. So as you can mention, Katie, my talk today is entitled Exploring Longitudinal White Matter Changes Across the Continuum of Psychosis. So I will begin today by presenting some background literature on schizophrenia, cognition, and how it relates to brain structure. And then I will try to answer some research questions. The first one is, can we replicate the finding that we see among enduring patients? And then are white matter differences visible in a first episode of psychosis cohort? And finally, does verbal memory relates to white matter? And then I'll conclude with a little bit of discussion where I invite everyone to jump in so we can have a group discussion. So first of all, schizophrenia and related psychosis are highly heterogeneous in their clinical representation. And the common characteristic of the disorder is often the presence of negative symptoms such as amotivation and flat affect, which are present often before the onset of the first episode and are still highly disturbing to the individual, even though they're a bit more subtle. And then we have the positive symptoms such as hallucination and delusion, which are a little bit more apparent and often the one that will bring the patients to consult at the clinic and get treatment. And throughout the continuum of this illness, there's cognitive deficit that are present, such as memory and executive function deficit. And so as I mentioned, psychosis can be seen on a continuum where we have first degree relative who are people with either siblings or parents who have schizophrenia or another psychotic disorder, but these individuals do not necessarily present with any clinical symptoms. And then in the high risk group, we have people that might be at genetics risk or not, but those individuals will often present with sub-threshold clinical symptoms. And when we get to the first episode of psychosis group, those are individuals that present with full-blown psychosis that have clinical symptoms that meet certain threshold to meet a diagnosis. But importantly, they're also still, it's very heterogeneous at this stages where having a first episode of psychosis does not necessarily mean you will end up being having a diagnosis of schizophrenia per se. It could be bipolar with psychotic feature or a schizoaffective disorder. So it's still a very heterogeneous population. And further down in this continuum, we often see individuals who have enduring schizophrenia. Those are individuals who have experienced multiple episodes of psychosis, have been treated for many years, and often have experienced some hospitalization period. So when we talk about first episode of psychosis patient, there's many advantages for studying such a cohort. So in comparison with high-risk individual, well, they already converted to psychosis. So it allows us to capture this critical window right after the onset and the acute phase to see what is going on. And in comparison with enduring patient or people who have been diagnosed for many years with a psychotic disorder, they have limited exposure to pharmacological treatment. They also have a limited number of hospitalization if it's not no hospitalization at all. And they also don't have the maybe the negative impact of having the chronicity of the illness yet. So it really allows us to circumvent any confounding factors that might be present in research involving individual with enduring schizophrenia or other psychotic disorder. So as I mentioned, in this illness, there's a lot of cognitive deficit that are present. So in this meta-analysis, they looked at first episode of psychosis in dark gray and chronic schizophrenia in light gray across multiple domain of cognition using various scale. And what they found, so on the y-axis, we have the effect size. And what they found is that they have mostly all large negative effect size, so generalized deficit, cognitive deficit that is present with this illness. And importantly, verbal memory is among the most affected cognitive domain in psychosis. and also in the first episode cohort. And so when I'm talking about verbal memory in the whole framework of memory, I'm really talking about long-term memory and specifically under episodic memory. So when we talk about experience and events or autobiographical stories, and it's this verbal component that is tested in many cognitive domains. And when we look at the cognitive deficit on a continuum, it also seemed to show like a degradation from stages. So in this study, they look at various groups cross-sectionally. So they have the LT control in dark blue here, first degree relative in purple, high risk in light blue, and then first episode here in green. And so across the cognitive domain that they tested, this one here being verbal memory, we see that there seems to be this gradation of impairment that is present, with first episode being obviously the most impaired and high risk and first degree being intermediate. So we're specifically interested in verbal memory because it has been shown to be a very good predictor of functional outcomes. So when we look at the literature, verbal memory in comparison to other cognitive domain has been linked to symptom remission, social functioning, as well as the capacity to live independently. And also even for high risk cohort, it's been shown that lower verbal memory has been associated with a higher risk of conversion to a first episode of psychosis. So there's a lot of clinical value to verbal memory. And when we look at the level of the brain, there are several studies among healthy individuals using PET and fMRI and various imaging modalities that have shown that verbal memory relies on a network of cortical regions, including the prefrontal and the medial temporal lobe. And these regions contribute in different ways to the memory processes, with the hippocampus being particularly important for the acquisition of new information, and the prefrontal cortex being important for the organization of that information. And similarly, studies that have examined the relationship between verbal memory and the cortex across the spectrum of psychosis showed, once again, using various imaging modalities, that the frontal and temporal lobe are consistently affected in this illness. And so this figure here comes from a selective review of cognition throughout the spectrum. And the blue circle here denote declarative memory. And what we see is that it's really the temporal, once again, the medial temporal lobe and the prefrontal cortex that have been associated with declarative memory. And those are also the regions that are impaired in the illness. So given all of those regional differences in the cortex, it led researchers to believe for many years now that schizophrenia and related psychoses might be a disorder of this connectivity. And so they started looking at white matter connecting those different regions of the cortex. I feel like I'm speaking very fast, so I'm going to drink a little bit of water. And so when we think about white matter, we think about diffusion imaging. And so diffusion MRI is a technique that allows for in vivo quantification of water diffusion throughout the brain and assess white matter structure. And one of the most common measure that is used in research is fractional anisotropy, which represent the directional preferences of water in each voxel. So basically when we get the image from the scanner, the diffusion acquisition, we do a little bit of processing on it, and we get this fractional anisotropy map. This one here being colored according to the direction of water molecules. So the green means it goes from interior to posterior, the blue from inferior to superior, and red from lateral to medial. And as we've seen in previous lecture, fractional anisotropy is constrained between 0 and 1, 1 being that the fiber are highly coherent. So there's myelin sheet, there's macromolecule that would constrain the water molecule to diffuse in one direction. And 0 being like isotropic diffusion. So there's no restriction at all. And so it's been postulated that higher fractional anisotropy means better coherence, being better integrity of white matter. So when we look at enduring schizophrenia patient, there's this study that has been published by the Enigma Consortium group that showed that there's widespread robust differences between patient and control, where we see that there's reduced fractional anisotropy in patient with moderate effect size from most of the region, basically. And so similarly to verbal memory, it seems like fractional anisotropy differences also seem to be on a continuum. So in this study, they looked at healthy control, high risk, and FEP cross-sectionally. And what they found is, once again, that first episode patient showed the lowest fractional anisotropy, with high risk being intermediate and then healthy control being the highest. So it seems like there's a progressive degradation also with the illness. So when we look more closely at the first episode of psychosis patient, we see that many studies have identified reduced fractional anisotropy in this group compared with control. So for example, there's a study here that looked at first episode patient, and they found also widespread differences, with the corpus callosum being showing the most robust differences in first episode psychosis versus control. And similarly, but kind of on the other hand, there's other studies that find more small cluster of differences of region that show reduced FA instead of widespread region. And it's also important to say that it's not all studies that seems to agree that there's actual differences in first episode group. So for example, just to show one among others, in this study, they look at chronic patient with their relative control group, as well as first episode of psychosis patient and the relative control group. And what they found is when they combine both patient group, they do find significant differences. And when they look only at the chronic patient, they find widespread robust differences, as has been shown in the literature. But when they look at first episode of psychosis patient, they actually don't find any statistical significant differences in the group. So the first question that we wanted to ask is, are white matter differences visible in the first episode of psychosis? So the first thing that we did was to confirm that our method was sound. So we did our imaging processing on a data set that was shared with us from collaborators. And this data set was from chronic patient. So what we did is we used a combination of software to correct for eddy correction, EPI distortion. Then we got our FA map. And then we followed the protocol suggested by the Enigma Consortium group to get the FA for each region of the GHU atlas. And all our statistical tests were corrected by using false discovery rate. So as I mentioned, this first data set that we did our analysis on is for injuring patient with schizophrenia. Also, importantly, this data set has been shared with the Enigma Consortium group, and I believe it was included in the first paper that I showed in the background. So, and also, so those patients are much older than what we would see in first episode of psychosis group, and they also have more medication. So what we wanted to see is, can we find similar results to what we've seen in the Enigma paper? And what we see here on the left is the GHU atlas, where we have control minus patients. So all the regions that are in the red, reddish color basically represent region where we see lower fractional anisotropy in patients in comparison to control. And the blue region is where we see higher fractional anisotropy in patient relative to control. And when we look at the effect size, we found a similar profile, if we can say it, where most of the regions show reduced fractional anisotropy and with large effect size as well. When we look at the distribution of the data here, we've used a GLM and covariate for age, sex, and years of education. And as I mentioned before, corrected with FDR. And we found many regions that showed significant differences between injuring patient and control. So from that, we can say that our method works, and we were able to identify similar results where injuring patients seems to show widespread, robust differences. So the next thing we wanted to do was to see if those differences were present, as I mentioned in the first episode of Psychosis group, and we used a longitudinal design to do so. So the time assessment for this new data set of first episode patient is, as mentioned here, it comes from the Douglas PEP clinic. And when they enter the clinic, and as soon as they are stable, which is usually around 3 months of treatment, they get their first assessment. So we have an MRI assessment as well as neurocognitive and symptom assessment. And then we have a second time point that is 3 months later, and then a third and a fourth time points that are 6 months later, respectively. And so once again, we use a similar imaging processing. The only thing that we change was we use FSL top-up here to correct for API distortion. The reason being this data set is high quality. We have both phase encoding, which is a requirement for FSL top-up. So we just basically increase the quality of our processing that we could do. And so in terms of demographic, as I mentioned, those patients are much younger. So they're around 24 years old. And they also have much less, a lower dose, I would say, of a medication. And so when we look at the data cross-sectionally, just for visualization, what we see is that the differences are very small, basically. So here on the left, it's the same as for injuring patient, where we have control minus patient. And so everything that is in the red color scale means that patient have lower fractional anisotropy, and everything that is in the blue color scale means that they have a slightly higher fractional anisotropy compared to control. And so it's kind of surprising to see that it's about half and half in terms of the region that shows reduced fractional anisotropy versus those who show increased fractional anisotropy. So I think we're kind of far here compared to, and this is, I forgot to specify, sorry, this is at baseline. So the first time point, so around 3 months after they enter the PEP clinic. And yeah, the profile is very different from what we see from chronic patient. And when we look at the fourth time point, so around 18 months after PEP entry, and a difference between 15 months from the first time point, once again, we see here the differences between control and patient. And we see there's a little bit more differences where patients show lower fractional anisotropy in the regions such as the corpus callosum, which was a little bit more higher at time point 1. And here I've put the previous figure for the profile of effect size. And what we see is like there's a little bit more region now that show reduced fractional anisotropy, but it's still not all region that seems to be affected. And here, when we look at the differences between the 2 time points, so time point 4 minus time point 1, and again, the differences between control and patient, we see that it seems like there's been a progression where there's slowly like reduced fractional anisotropy in the patient, but those differences took time. So when we look at the longitudinal data, and specifically the analysis that we did, so we've used a mixed effect model with an independent intercept as well as independent slope for both groups. And when we look at the results that we found a significant mean effect of time for the Cingulum. So here what we can see on the x-axis is the days since baseline. So we have our fourth time point that we see, basically, and the fractional anisotropy for the cingulum. Specifically, it was the interior part of the cingulum. And what we can see is that patient seems to show a slow decrease in fractional anisotropy over time, whereas control remains stable here. And that survived correction for multiple comparison. So when we think about the cingulum, here I'm showing just the interior part, which is the one that showed significant differences. And when we think about the cingulum, it's a big association fiber that connects the temporal lobe and the frontal lobe together. And it's been shown to play a role in both for emotion and cognition. And it's also a tract that has been affected for injuring patient, as well as in other studies for first episode of psychosis, where they seem to show reduced fractional anisotropy in this region as well. And I think it's also important to mention that this tract has been shown to be affected in many other mental health illness, such as depression, ADHD, PTSD, OCD. So I think it could be interesting to see if it's this differences that we see that seems to be slow and appearing being the first tract to show differences. Maybe it's actually related more to a general like mental health disorder rather than specifically to psychosis. So I think it's just interesting to see that this tract is really involved in many different illness as well. So what we can conclude from this first part is entering schizophrenia really show robust group differences in fractional anisotropy. And regarding the first episode of psychosis cohort, it seems like the cingulum is among the first tract to be affected in this cohort. And finally, I think it's important to keep in mind that group differences in regional FA are very small early in the illness, and the progression seems to occur very slowly. So it might just be that, yeah, the brain takes time to change. And so the second thing that we wanted to see was whether verbal memory relates to white matter. So when we look at the literature for white matter, we see that in healthy individual, the fractional anisotropy of the fornix has been associated with verbal memory. So when we talk about the fornix in this figure, it's the number 7, so it's here. And the fornix is a tract that is connecting the hippocampus to the mammillary body, which are in the frontal lobe. So it's basically a good pathway for memory if we think about the hippocampus being central to memory. And when we look at the studies that have looked at this association in enduring schizophrenia, there's a few studies that have found association with different tracts. So there's a study that found an association with the uncinate fasciculus. So again, the uncinate fasciculus is this blue tract here that connects the inter temporal pole to the frontal lobe. And the fornix as well has been associated in schizophrenia with verbal memory. And importantly, there's also the interior limb of the internal capsule. So this is this tract here, kind of light pink. And the interior limb of the internal capsule is basically connecting the thalamus to the frontal lobe. And in first episode of psychosis, it's a little bit less consistent. So there's many studies that have looked at different neurocognitive domain. And there's only one that found that the uncinate fasciculus was related to verbal memory. So once again, this is this light blue tract here that connects the temporal lobe to the frontal lobe. So in this study, we measured verbal memory using the Wechsler memory scale. So this scale is composed of 2 short stories, and we read those short stories to the participant. And right after the story has been read, we asked them, what do you remember from the story I just read to you? And there's about 25 keywords that we're looking for. And then we look at how many do you remember. And then we do self-reporting scales and questionnaire for 30 minutes. And 30 minutes later, we ask them again, what do you remember from the story I read to you about half an hour ago? And so we see how much you remember. And so those are both the immediate recall and the delayed recall. And there's also a recognition part where we just ask them question and they answer by yes or no, whether it was included in the story or no. So when we look at verbal memory over time, so here on the x-axis, we have the days since baseline. And on the y-axis, we have the Wechsler, both immediate and delayed score. And what we see is that control consistently performed better than patient over time for both immediate and delayed recall. And the other thing that is interesting is was also a bit unexpected for us was that both groups seems to be improving with time. And so one thing that we thought about is obviously it could be a practice effect, considering that they have 4 time points, even if they are months apart. There's a possibility that they remember a little bit what the story was, since we're using the same story. And the other part is also maybe they know like how they're going to be tested. And so they can prepare a little bit better to, oh, I have to remember all those key components from that story. And there's also especially for the patient group who seems to be improving a little bit more rapidly here for the immediate recall, there's also the possibility that either medication could have a positive effect on verbal memory. And there's also the possibility that patients are taking part into different like psychological treatments, such as cognitive remediation therapy, that could potentially help them develop techniques to remember a little bit better. So we can discuss this together later, because I think it's interesting that we see.
Oh, yeah, I have a question actually about this. I was wondering at time point 4, is it such that the patients are now indistinguishable from controls? Have they, has their verbal memory normalized?
No, they're still performing lower because control are also improving. So it's never actually normalized. So yeah, I don't know if that answers your question.
Yeah, thanks.
And when we look at the association between verbal memory here and fractional anisotropy, we found that there's a regional effect of verbal memory as well as an interaction per group for the superior fronto-occipital fasciculus. So what we see is that for control, better verbal memory is associated with higher fractional anisotropy, which seems to conceptually make sense. That's what we would expect. And surprisingly for patient, what we see is better verbal memory is associated with lower fractional anisotropy. So that this was a little bit surprising at first, and what the explanation that we came with, and I'm hoping to other suggestion as well, is the first thing, maybe there's a bit of attrition from the patient group. So we can imagine that this is over 15 months, they come to the lab 4 times. And if patients are having the first visit and they have poor, like they find that the assessment are hard and they perform poorly, they might not want to come back at all. And so maybe everyone who has lower verbal memory to start with just decide not to come back, or lower cognition in general. So there's this possibility of attrition that could maybe impact the analysis here. And the other thing is, as we've seen, there seems to be a slow reduction in fractional anisotropy over time. So it's possible that for fractional anisotropy, we have a decreasing slope, whereas that for verbal memory, we have an increasing slope, and using a mixed effect model might not allows us to map one to another very well. So I think other analyses are required to very pinpoint what's going on here, but it's still very interesting to see that there's this relationship for both groups. Another thing that I think is important to mention is when I mentioned like the superior fronto-occipital fasciculus, I feel like this name is a little bit misleading in the atlas because you would think that it really connects the frontal lobe to the occipital lobe all the way back. But in reality, this region is really part of the anterior limb of the internal capsule, and it's this green part here that just sits on top. So I don't really know why they distinguish both region actually in the atlas. So what we see is really this green region that seems to be associated with verbal memory. And it kind of makes sense because what this region captures is really the tracts that are connecting to the frontal lobe coming from the anterior, not the anterior, the thalamus. So it's really, and we know that the thalamus is kind of this gateway to all the sensory input that are coming to us, and the frontal lobe being important for the organization of information. I think it's conceptually making sense that this tract could be related to verbal memory. And so from this study, what we found is that control consistently performed better on verbal memory tasks relative to patient. And surprisingly, as I said, both groups seems to be improving over time, which it's also good when we think about it, if patients find ways or technique to remember better and improve when they have multiple assessments. And it seems like verbal memory relates to the fractional anisotropy of the superior fronto-occipital fasciculus differently between groups, where we saw that there was this positive association between verbal memory and FA for control, and this negative association for patients. And so to bring the two studies together, it seems like the Cingulum is the first track to show fractional anisotropy differences in first episode of Psychosis, where it seems to really show a decrease in fractional anisotropy over time. And as I just mentioned, control consistently performed better, and that is true for every single time point that we had. The verbal memory, as I said, seems to be relating differently to the superior fronto-occipital fasciculus for groups. And I think the take-home message from that is it seems to suggest a possibility for preventing fractional anisotropy reduction early after the first episode of psychosis. So we didn't find statistically significant differences between both our groups for the track that we looked at. And so it means that there's maybe this possibility of if medication could improve or maintain the level of myelination or macromolecule, whatever that consists of white matter. So I think it's really a hopeful statement that we can see here. And so when we think about the two studies that I presented to you, and in terms of limitation, and not specifically to the two studies that I've shown to you, but really more in terms of when we find ourselves with those results and we compare our results to other. I think there's many things that can lead to discrepancies when we look at different articles that are out there. The first one being, as I mentioned, the first episode group is very heterogeneous. And when we look at studies that look at schizoaffective disorder versus schizophrenia or bipolar, all those groups seems to show different impairment, different cognitive impairment, and also different level of reduction for fractional anisotropy. So maybe the fact that our group is so heterogeneous makes it hard basically to compare results. And it's the same with the first episode of psychosis definition that we see in the research literature, where some people would include individuals who are only inpatient who have been hospitalized and all of that, whereas in this study we include patients that are quite functional, that are following, we follow them in a naturalistic design. They're not living at the hospital, they're not hospitalized at all. So this could potentially change the way we interpret our results. And there's also the genetics risk that the patient has. So it's not, we didn't do any genetic tests or anything, so we cannot know whether our patient are at risk genetically, or if it's be more of a clinical population that we have. And like in the literature, when we look at high risk individual, we see that those who have a genetic background that put them at risk often show more robust differences early on compared to those who only present with clinical symptoms. As I mentioned, for the verbal memory aspect, there's also pharmacological treatment that could potentially help for cognition, and hopefully maybe also for white matter. That remains a little bit unknown in terms of what is out there. There's also the way we compare and we look at white matter. There's so many different techniques out there, whether it's voxel to voxel, looking at region of interest, and whether people are using fiber tracking. So this is always something to keep in mind also when we compare results. And there's so many cross-sectional analysis, but we don't necessarily see many longitudinal analysis out there. And I think this is really important, and it brings me to the more like the strength of this study. And I think it's really important to keep in mind that we've used a longitudinal data set. So we really look at patients early on after the onset of psychosis and for 15 months. So I think we have a very beautiful data set and a good window that we can capture that we don't see actually white matter differences or that are statistically significant. And so it really gives us like a hopeful statement for patients that are experiencing a first episode of psychosis when we think about white matter. And importantly also, individuals are recruited from the specialized early intervention service here at the Douglas. And it comes from a local catchment area, which makes the simple epidemiologically representative, I would say, from the Montreal Southwest. And finally, I think we showed like in a good way that our method and imaging processing was sound by validating the way we process our imaging on the entering patient group. So in terms of future direction, I think it would be very interesting to see how medication impact white matter. And it's a good thing that we have this data set available, because there's another student in Martin's lab who is supposed to look at this longitudinally. So there's many studies that have looked at the cortex and the impact of different antipsychotic on cortical thickness or gray matter, but we don't have much information on the impact that it has on white matter. So I think this is going to be very interesting, and specifically if they can find one that seems to be protective a little bit of white matter degradation. And lastly, I think it would be interesting also to use this longitudinal analysis to relate how network changes can relate to cognition, and if we see good markers for cognition. So I would like to thank both my supervisor, Martin Lepage and Malar Chakravarti, our collaborators who shared with us their data set for enduring schizophrenia, so Gary Donahoe and Lorena Holren. And also a special thanks to all the other members who helped me with those analysis and computational challenge that I faced. So Katie, Rehan, and Greg, thank you very much, and everyone that is part of the lab. So if you have any question, it's the time. And yeah, I said it went quickly.
Thanks, Charlie. Does anybody have any questions?
I have a question.
Sure.
Back at the beginning of your introduction, when you were providing the background, you mentioned that one of the challenges, especially comparing chronic schizophrenia to first episode, is that there's almost always like this big age gap. And I was curious if, knowing that like a lot of women, there's kind of that second spike of a first episode around menopause, if there had been any studies that took a sample of older women, primarily women, I guess, experiencing that first episode later in life, and compared it to chronic individuals with chronic schizophrenia at that age group, and healthy controls matched to that age?
That is a very good question. I haven't looked at this at all, considering the PEP clinic really recruit from 14 to 35. So we don't necessarily capture at all this later onset among women. And I haven't also looked at sex differences in white matter. So I'm sorry, I don't have a good answer for you, but I think it's very interesting. And I'm sure there are probably studies that have looked at this.
It'd probably be a pretty niche sample. I don't even know what like the raw numbers would be.
It must be hard also to recruit when you think like this is so precise and
Totally.
later.
Yeah. But it would be an interesting way to like mitigate the effects of that age difference.
Yeah.
Any other questions?
Yeah, Charlie, I had a couple questions. Firstly,
Hi, Charlie.
Hi. I am not turning my video on because I just came back from a run, so I don't know. But anyways, I just wanted to say, firstly, I left the lab when you were still struggling and wrestling with the data, and I feel like you've come so far, and it's really, really nice to see the completion of this project. So yeah, just congratulations. This is a great talk. So one quick question I had about methods, or about one of your results, and then another more broad question about methods. The first one, you showed the superior fronto-occipital fasciculus association with the interaction between patient and controls, and
later.
And you basically, yeah, this one. So, and you were kind of trying to think, why would you have lower FA in patients in this track with higher verbal memory? I was just wondering, just that green line in and of itself, is it significant? Is there a significant negative correlation? Because it looks flattish. Well, I guess it's going down a bit, but.
Yes, so there was really this verbal memory. I don't have the p-value right, like on top of my head. It was significant, but it wasn't strong. I think it was like 0.03 after correction from multiple comparison, but it was still significant. And one thing that I found that was interesting in the FEP data set, so the 1.5 Tesla, we also found this association, trending association for the patient group, but the direction was opposite. So where it was similar to what we see in control, where higher verbal memory is associated with higher fractional anisotropy for the same track. So what I found that was interesting is when we look at the data cross-sectionally, we see a positive association. But when we look at it longitudinally, because we have this increase in verbal memory performance over time, we kind of shift the orientation of the correlation.
Okay. Okay, that's interesting. But this actual track, because when you showed it on the atlas, it's really like a small region, like it's not actually, or is this atlas really capturing visually what the track looks like? So it's not, like you said, joining the occipital lobe at all. So it's just this small.
And the definition in the Morris paper, what they're saying, it really captures the frontal like fibers that are passing through this region. So as we said, like it doesn't go all the way back. So I'm thinking it might just be more representative of like the frontal lobe being affected in schizophrenia, and specifically maybe white matter.
Yeah, and so this will kind of lead more into my broad methods question. Especially with the enduring schizophrenia samples, we tend to see group differences in tracks that are a bit easier to define. So you tend to see effects in corpus callosum, the corticospinal tract, and you know those are just easier to get more robust measures of FA. So I always wonder when we're looking at these, results from the Enigma or other large samples, how much are those associations just because we can measure them really well, where there might be, important differences hidden in these harder to measure tracks like the fornix, and that's where Millar's atlas has been really great. Yeah, I just wanted to get your comments on, the results that we see at a clinical, application level, and in the robustness of actually measuring some of these tracks.
Yeah, I think you're absolutely right. And that's why we try to improve like the MRI acquisition and all of that, but it always remains, I think it's hard, especially for the subcortical region, mapping the track that connects to it. And even like the fornix, it's so small. So as you said, there might actually be differences there, and it's just the fact that in enduring patient, they are more aggravated maybe, that explain why we see those group differences. And I forgot my train of thoughts here for what I wanted to say. But yeah, and also in terms of white matter volume, I don't know if the resolution of scanner and what we see in terms of assessment, it might be easier to capture, because we often see differences in volume. There's many like articles that will see differences in white matter volume, but won't necessarily capture differences in fractional anisotropy.
Right.
So as you said, it might be a limitation of the way we assess and the way we use the atlas. So.
Because for instance, like here, you haven't seen, I don't think, any differences with fornix, with FA, but when I had looked at this data set, and obviously it was preliminary because it wasn't the full LAM data set, we did find differences though in, for instance, the quantitative T1 of the fornix as defined by the Maggot Atlas. So I just think that there's some of these tracks that are really interesting, but just with DTI, it can be difficult to measure.
Absolutely, yeah, absolutely.
Anyway, thank you.
I might have 2 questions for you, Charlie, if it's okay. More for the first part of your talk. So you showed in the FA, you had results going in like both directions. So I was just wondering if you looked at other diffusion measures where maybe you see a consistent pattern in different regions, and maybe that could help you identify maybe more strong differences between, let's say, controls and patients.
Yeah, I didn't, because I needed to graduate at some point.
That's a good reason.
And it took me, to be honest, it took me a lot of time to conceptually wrap my head around diffusion analysis and do the processing and all of that. So it would totally be the next step to do. And I mean, we process this data up to tractography. So we have all the connectomes for them as well.
That's cool.
Which initially was the focus of my thesis. And so, yeah, absolutely. The next step would be to look in different measure, whether it's MD, RD, or AD, whether some of them capture maybe more of the differences or earlier on.
Great. And maybe it's just to get a sense, because you've looked at, probably you didn't do it, otherwise you would have shown it, but so let's say like the Cingulum, where you saw this difference over time, I was wondering, do you think looking more at an individualized measure, so like change within the patients, do you think some, let's say you would see associations with maybe symptoms or cognition, or you think these like changes are too subtle even when you look like at each of your patients? I was just wondering like what you think of that.
Yeah, we haven't looked at the individual level. Neither did I look at with symptoms or anything, but I know that according to the literature, there's, I think there's more chances for white matter to be related to symptoms and medication, or at least more robust, being like more robust to, compared to cognition, because there's a lot of literature on that, and often people will find very good association. So I think symptoms and white matter is definitely there, as well as I'm guessing medication we could find.
That's cool. And as you mentioned that in the end, but yeah, it's really nice. I think that you're looking at longitudinal design in this study. So yeah, good talk.
Thank you very much.
Does anybody else have any questions? Okay, I'll ask you one, Charlie. A simple one, I guess, to start. I was just wondering, I think I missed it, but did you see differences in verbal memory in terms of effect sizes between the enduring sample you worked with and the effect samples at baseline? Were they less impaired, or?
I couldn't look at this, considering that we didn't have the verbal memory assessment for the enduring patient. So they sent us the scale score, which kind of groups people together on like certain level. So we didn't have any raw score or Z score or anything. So it really limited the how we could analyze the data for enduring patient related to verbal memory, unfortunately.
And did you think about some other cognitive domains, for example, like you know, attention or processing speed that might be related to these, to like verbal memory tasks that they're doing? Is, you know, something like a general cognitive impairment may be accounting for this?
I didn't look at this. According to literature, I would say executive function and speed of processing seems to be the one that are the most often associated with white matter. In other studies that have looked at like many different cognitive domain, it could be that it's a generalized like cognitive deficit that we see, and it's not necessarily specific to verbal memory. I would say that attention, I think, plays a huge role in this, especially for the story that we're telling. Like, even if they're short stories, it's maybe like like 3 or 4 sentences that we read to the person, but there's so many details in them that if they don't pay close attention, or if they space for a second, it's really easy to miss many points that they could have. So yeah, attention plays a big role in there.
Anybody else?
I have maybe a question, Charlie. It's Genevieve. Hi. Congratulations for your presentation. It was amazing. You mentioned earlier that it might be interesting to talk a little bit about all the treatments and things like that. And while we were discussing, I just had the idea that maybe one possible explanation for this is that, especially for first episode patients, if they have concurrent psychotherapy, it's very verbal. So maybe there's even like a training component, just not necessarily targeted, but just like indirectly by seeing a professional every week. And most of the time we ask them, so what have stayed with you over the week, or what do you remember from last week, and things like that. So maybe that's one possible
Absolutely. And I think even if we go kind of even more general than this, often people will be a little bit more isolated because of illness. So just going to therapy, seeing people, talking with other members of the group or things like that can potentially have a positive effect, and just being stimulated.
Thanks.
I had another question to go back to the imaging, actually. And you mentioned just earlier in one of the answers that you have data for tractography. Is that something that you're planning to look at?
We kind of looked at it a little bit. I didn't look at it longitudinally, as you know. I think it would be interesting. One thing that really limited my, like how fast this master happened and what I could do is obviously the computational skills that it requires to do all those analysis. So I think it would be very interesting to maybe pair up with someone who like have a collaboration with someone who has those skills and is interested in looking at a network analysis longitudinally. And like the data is there, so we just need the little brain to code.
Great. If there are no other questions, I'll give it a few seconds. But otherwise, I'd like to thank Charlie for her talk. So everyone can unmute or use your reactions to clap for her. So thank you, Charlie. That was great.
Thank you. And thank you for the invitation. It was great.